Yes,
Sir.
sir. Okay. So, pathophysiology and management of post-op shivering. Most of the points are covered well by Risha. So, shivering is a syndrome involving involuntary oscillatory contractions of skeletal muscles. This is the definition for shivering. It is a contraction, oscillatory contractions of the skeletal muscle, which is common as an effect of anesthesia and targeted temperature modulation. It is a physiological response to cold exposure of bodies next to for heat preservation and after peripheral vasoconstriction. So peripheral vasoconstriction is the first method of preventing losing heat from our body, and shivering is the next method, physiological method of generating more heat. So vasoconstriction prevents the loss of heat, and shivering generates heat so that the body's core temperature comes back to normal. So postoperative or perioperative shivering is involuntary. You cannot control it. Even when you ask the patient, don't do that, he cannot stop. So oscillatory muscular activity during early recovery after anesthesia. It is defined as a fasciculation which can happen in the face, jaw, head, or muscle hyperactivity. It should be lasting more than 15 seconds each time that they start doing it. And this is the fundamental figure which is recorded with the electromyogram, where it happens at 200 hertz cycles. The basal frequency is about 4 to 8 cycles per minute in a waxing and waning pattern. And there are two different patterns of shivering. One is called tonic pattern, similar to normal shivering, and the phasic waveform, similar to pathological clone. So in the tonic pattern, it shows the constant sinusoidal form of normal shivering, and it seems to be a thermoregulatory answer to intraoperative hypothermia. Whereas the clonic pattern is not normal. It is not a normal component of thermoregulatory shivering, and it is a specific form of recovery from volatile anesthesia, especially volatile anesthetic like isoflurane and earlier halothane. It used to be called as halothane shakes. Patients who come out after halothane anesthesia, even if the ambient temperature is 38 or 39, quite warm room, they still will have some amount of movement, which is called halothane shakes in those days. So this pattern of shivering might come from loss of inhibition produced by general anesthesia in the spinal reflexes. So this is the mechanism of what is called the clonic pattern. Whereas the tonic pattern is a type of shivering which is physiological, which is stimulated to generate more heat, and it is elicited by which region of the brain is important. This is the preoptic region of hypothalamus, which gets cooled by the drop in temperature. So what happens? The hypothalamus sends different signals mediating shivering descent in the medial frontal bundle. So spinal alpha motor neurons and their actions are the final common pathway for coordinated movement and shivering. So a typical cold tremor sends a group of discharges in the continued cold stimulation of the skin and spinal cord leads to motor neurons being recruited more and more in number in sequence by increasing size, starting with small gamma motors. Of course, you all know that there are three different sizes of motor neurons. So gamma motor followed by alpha motor neurons, and the large basic alpha motor neurons are recruited. So all the muscles start contracting. That is why the first definition, it is a contraction of the skeletal muscle, is very important. And in surgical patients, it has been demonstrated there are two types: non-thermoregulatory shivering in normothermic patients. So if you take the temperature of the patient, the temperature of the patient may be normal, but still they may have shivering. So this is called normothermic postoperative shivering. And the tonic stiffening pattern of muscular activity was noted in non-temperature dependent effect of isoflurane anesthesia. And another observed pattern is spontaneous electromyographic clonus that required hypothermia. So isoflurane can produce two types of shivering. One is normothermic shivering, another is hypothermic shivering, and depends on the concentration, residual concentration of isoflurane in the end tidal expired air. So larger the concentration, patient will have abnormal pathological clonic type of shivering, and they will be hypothermic if you record the temperature. Whereas in the normothermic patient, the concentration of isoflurane will be very minimal, but still they may have some sort of stiffening of the skeletal muscle. It will not be the classic pattern of shivering. It will be some sort of stiffening of the muscles, which will indicate that they are still have that, and patient will be saying, "I'm not comfortable." So the shivering score, as Risha correctly said, there are 4 grades. 0 means no shivering, and in grade 1 score, you have a mild fasciculation of face, neck, and electrocardiography disturbances are present in the absence of voluntary activity. And in grade score 2, you will find visible tremor in the muscle groups. And in score 3, muscular activity involving the entire body is there. Violent shakes will be there. Coming to the etiology, the cold-induced thermoregulatory shivering remains an obvious etiology, and the phenomena has been attributed to other causes. It is not only the temperature which is responsible. Patients in pain also can shiver or make the shivering movement, or disinhibited spinal reflexes, or decreased sympathetic activity. Patients who are hypotensive with a decreased sympathetic activity, they also will start shivering. And if they have respiratory alkalosis, so these are all the other non-thermic causes of shivering: pain, disinhibited spinal reflexes, decreased sympathetic activity, and respiratory alkalosis. And the conventional explanation for post-anesthetic tremor is the anesthetic-induced thermoregulatory inhibition. That is what is called the patient changing from homeothermic to poikilothermic nature, and inhibition abruptly dissipates and increases the shivering threshold towards normal. So this discrepancy between the persistent low body temperature and the near normal threshold activates simple thermoregulatory shivering. Now, perioperative hypothermia is defined when the core temperature of the, that is this, and rectal or the esophageal temperature, that is called the core temperature, not measured from the axilla or the esophagus. So 33 to 35 degrees centigrade, while shivering threshold is non-anesthetized patient is 35 to 35.5 degree. So anesthetic agent increase the heat response threshold and decrease the cold response threshold, so that the normal interthreshold range is increased. That is what is happening and causing this. One of the important functions of the rostral ventral medulla is to modulate the amount of pain and temperature input ascending from the spinal cord by getting the transmission of neuronal signals to the dorsal horns. So this is another transport mechanism. And shivering can be divided into two types. Most common is the thermoregulatory shivering, which correlates with cutaneous vasoconstriction in response to hypothermia. In contrast, 15% of the shivering patients form non-thermoregulatory shivering. As I told earlier, they can be normothermic or hypothermic. The first category, thermoregulatory shivering, is the hypothermic patients. In the non-thermoregulatory patient, there is actually a cutaneous vasodilatation, and that may be probably because of pain. So if the patient has got no cutaneous vasoconstriction and his temperature is normal, you must think of pain as the cause of shivering, not as the temperature as the cause of shivering. So you have to classify them into non-thermoregulatory and thermoregulatory. Now, what are the clinical impact of this? Important function of shivering is elevating the body's core temperature. So shivering is uncomfortable. For some, even find the accompanying cold sensation worse than the surgical pain. So very sensitive patients, especially when you do a surgery under spinal or a plexus block, if the patient is very sensitive to cold, then they will be, even though the operative area is totally pain free, patient will never be comfortable. He will be going on complaining. So the post-anesthetic shivering increases oxygen consumption. It also causes lactic acidosis and carbon dioxide production, and catecholamine release. These are the four important changes that happen. Increases the oxygen consumption, produces lactic acidosis, increases carbon dioxide production and catecholamine, resulting in increased cardiac output, heart rate and arterial pressure. It also impedes monitoring techniques. So it disturbs, especially ECG will go haywire. If the body is, all the skeletal muscles in the chest and the abdomen, they start shivering, contracting. Your ECG recording will not be normal. It also increases intraocular and intracranial pressures, and especially disturbing to mothers during labor and delivery. Some of the patients who undergo normal vaginal delivery, they start developing shivering due to some reason, either the non-thermoregulatory or thermoregulatory. That will be very uncomfortable for them. And vigorous shivering increases metabolic heat production up to 600%. And increases oxygen consumption also anywhere between 300 to 400% with the risk of hypoxemia. And it can lead to critical ischemia in the postoperative period. It is also associated with adrenergic and sympathetic hyperactivity, lead to myocardial ischemia. And shivering causes patient discomfort and the likelihood of postoperative complications like infection, pain, bleeding, and sometimes wound dehiscence. All these things can happen because of the shivering. And it's also associated with delayed wound healing, increase in hospital stay, and metabolic requirements predisposed to intrapulmonary shunts and decrease the respiratory reserve. How do you treat that? Any therapeutic strategies? Two main methods, you can classify them into pharmacological and non-pharmacological anti-shivering methods. Non-pharmacological methods are forced air warming, most common method we use every day, and passive cutaneous warming, like just putting a cotton blanket or covering the body with heated fluid, or active cutaneous warming with electric heating, water circulating garments, etc. So these are the non-pharmacological. Coming to pharmacological therapy, many drugs have been shown to be effective. Now, what is the mechanism? How they do it is, it is tightly regulated by a complex and multi-level control loop, including participation of thermal receptors, spinal cord, brainstem, and anterior hypothalamus and cerebral cortex. So by incorporating all these areas, some drugs are able to help in control of the shivering. So the highly effective anti-shivering medications are the first among them is tramadol or meperidine and fentanyl, cholinesterase inhibitors like physostigmine, and NMDA antagonists like ketamine and magnesium sulfate. These are the most effective drugs. To some extent, lesser effective drugs are clonidine, dexmedetomidine, and ondansetron or granisetron, and anti-inflammatory agents like dexamethasone all have been tried. So these are the points that you have to remember and include in your answer for shivering. Okay.